Welcome today to EHJ Today in Davos at the Cardiology Update 2017. I am Laurent Haegeli, electrophysiologist at the University Heart Center in Zurich, and I have the pleasure and the special honor to be joined today by Professor Hugh, Calkins, Director of Cardiac Arrhythmia Services at Johns Hopkins Hospital. So my first question to you, Hugh, would be what is new today in AFib ablation in 2017?
Well, Laurent, there's a lot that's new. I think one important message that we've learned is that isolation of the pulmonary veins is the cornerstone of AF ablation, and we've known that to be true for a long period of time. But now, in the light of the recent STAR-AF study, the study that showed that linear ablation and cafe ablation added little to PV isolation alone, we're now re-examining these additional strategies other than PV isolation. We have lots of new strategies. We have rotor ablation and scar ablation and autonomic ablation. And the question is which one is best? When should they be employed? So it's a very exciting area for research, but a lot of questions remain uncertain.
So what would be then your optimal candidate for to be referred to you for AFib ablation, and which would be a poor candidate, and which would be the outcomes of each patient?
In my mind, the optimal candidate has paroxysmal AFib. They're between the age of 30 and 70. They're otherwise healthy with no major comorbidities. And in that kind of patient, the single procedure success rate is 60 to 80%, and with multiple procedures, you can get a 70 to 90% cumulative success rate. I think what defines a poor candidate, the number one thing is how long has a patient been in AFib continuously? And if it's more than 3 years, and particularly if it's more than 3 years of continuous AFib with evidence on an echo of a large left atrial size, 5.5, 6 centimeters, I think that's a very poor candidate for AF ablation, where the single procedure success rate's probably less than 30%, if you're honest.
So in the European guidelines, patient with symptoms and paroxysmal AFib after failure of the first antiarrhythmic drug is a class 1 level A indication for AFib ablation. So what about a patient without symptoms and paroxysm of AFib at a younger age? We know that we have not a lot of data supporting interventional therapy of AFib, but how do you deal with these patients in your clinical practice, Hugh?
Well, Laurent, this is I think a very interesting question now is about these asymptomatic patients. I think everyone will agree that if you see a patient in AFib continuously and they say they have no symptoms, I think most electrophysiologists will restore sinus rhythm with cardioversion and reassess their symptoms, because many of them will define themselves as being symptomatic, and you can do an ablation under current guidelines. The fascinating area is ablation of the truly asymptomatic patient. And this morning we heard Karl-Heinz address this in his lecture, and he made it very clear he was born in sinus rhythm, he wants to die in sinus rhythm, and even if he had AFib, if it was asymptomatic, he'd want an ablation. I would too. So it's going to be very interesting. We're redoing the HRS ERA APHRS consensus document on AF ablation for the first time in 5 years. It will be published in May, and this is one of the issues that we're addressing. I know my personal perspective is that in highly select patients, even if they're asymptomatic, that catheter ablation is reasonable, provided the person doing the procedure is highly experienced, and provided you've had a lengthy discussion that you're performing this procedure largely for theoretical reasons. The theoretical benefit of being in normal rhythm for reduction of stroke, for reduction of sudden death risk, for reduction of dementia risk, for reduction of heart failure risk, All unproven. East and Cabana may answer some of these questions, but I believe it's appropriate in very select patients, but it will be great to see what the consensus document ends up reporting. This is a 61-author document from 5 different societies, so I think it will be an interesting area that will be addressed in that document.
So we're looking forward to have this consensus document in May of this year, you said, and we are looking forward to get data prospectively controlled on this outcome from East and Cabana, hopefully next year or in 2 years, to show that AFib ablation not only improve quality of life, but also stroke rate, heart failure, and mortality. What do you do with patients who wants to have AFib ablation straight at the first line?
Yes, if you look at the current guidelines on first-line ablation, they're clearly allowed. They're a class 2A, meaning if someone is paroxysmal AFib and they're symptomatic and they don't want to take an antiarrhythmic drug, it's very reasonable to go first-line to ablation. Now, that said, most busy electrophysiologists have a waiting list. And during the waiting list, there's very little reason not to try an antiarrhythmic drug. And if it works, a patient may choose not to have the procedure. I think another very interesting group where first line makes lots of sense are patients with tachybrady syndrome. They have sinus bradycardia, or they have AFib and they have a pause. You don't want to put this patient on flecainide or propafenone or sotalol. You're reluctant to put in a pacemaker. There's now a lot of data saying that ablation in that patient is very appropriate first line and may eliminate the need for a pacemaker because you alter vagal tone. And so I think that's, or high-level athletes is another subgroup where these patients just don't want to take antiarrhythmic drugs, and first-line ablation makes lots of sense. But yes, I think that's important. There's been 3 or 4 studies that have been generally positive, so I'm supportive of it.
So I fully agree with you that the first-line treatment with ablation is a valid option in young patients and experienced hands. So going beyond ablation, we are electrophysiologists, we like to see the signals, we like to freeze or to burn, but going beyond this arrhythmia, these patients have a lot of comorbidities, hypertension, obesity, and how do you see this in an integrated approach of the disease of AFib ablation?
Well, I agree with you completely that now I think the data is stronger and stronger that we have to pay attention to the comorbidities. I refer to it as the 4th pillar of AFib management. You have anticoagulation, rate control, rhythm control, but I think risk factor management is the 4th pillar. And in every patient, we need to address if they're obese, they got to lose weight. If they have sleep apnea, or if these screening tests suggest sleep apnea, you should screen for it and treat it. Hypertension, you should treat it. So I think it's very important. I think the early data, much of it from Prosh Sanders is very encouraging. And in my own personal experience, it really seems to help. The challenge, of course, is telling someone to lose weight is a lot easier said than done. And I don't think many of us have sort of obesity clinics linked to our EP clinics. So I think we need to have more emphasis on the team-based approach and comprehensive care and this kind of thing. But yes, I think it's very important.
So AFib ablation is superior to antiarrhythmic drugs. We know we have results of 70 to 90% of success with one or multiple procedures in patients with paroxysmal AFib. But the method is good, but not perfect yet. So what do you think will be the next steps? How we will improve that? How do you see AFib ablation in 5 to 10 years?
I mean, the striking thing about AF ablation is we've always said that PV isolation is the cornerstone of the procedure. And yet, even today, 15, 20 years after this journey started, if you take a patient back to the EP lab who's failed an AF ablation, almost always one or more pulmonary veins have reconnected. So, I'm very hopeful that in the next 5 years, we'll be able to permanently isolate the pulmonary veins with one procedure the first time. And once we can do that, then we can really get serious about addressing these other strategies, non-pulmonary vein triggers, autonomic ablation, scar ablation, rotor ablation, in all these new areas. Personally, I don't think there's going to be some revolutionary approach that's going to show up tomorrow and change dramatically what we're doing. For example, some have proposed radiation therapy for AF ablation. Forget the catheters, close our EP labs, and just get a radiation therapy machine. I don't think that's going to be the answer. I think we'll be having better tools, incrementally better results, and I think we'll get the single procedure success rate in a good candidate to 90% within 5 years.
So, Hugh, I think this was a very nice final word. It was great talking to you, and I thank you for this nice outlook in this conversation, and I wish you a nice day.
Thank you very much. It's great to be here.
Thank you.